Now, localizing AMI by EKG. If it's ST elevation, what are we going to do? We're going to localize. So what we'll take a look at next, and I've referred to this already. Now, as I said, we're going to repeat. In a couple of lecture series ago, I talked to you about blood vessels and their respective EKG leads, right? So now we're going to take a look at a table and we're going to harp on that very fact. ST depression, what does that mean? It doesn't localize, but what do you call an ST depression type of MI? You call that a non-STEMI. Is that clear? It's not an ST elevation, it's an ST depression. So how can you tell the difference? Let me ask you this question so that you're clear. How can you tell the difference between an ST depression that you found with stable angina upon administering a stress test versus an ST depression that you might find with the myocardial infarction? You answer that question, please. Cardiac enzymes. Good. Cardiac enzymes, are they ever found in angina? Never. Clear? It's that clear. And it should be. Cardiac enzymes will not be found in stable or unstable angina. So if you find an ST depression and you find no cardiac enzymes, high on your differential should be stable angina. If you find an ST depression and non-STEMI with cardiac enzymes, what's your cardiac enzyme again? A troponin I, it brings you to ST depression. Is that clear? MI. Now, here we go. Told you earlier that we were going to walk through the different coronary arteries and its respective ST elevations, arteries. I very much wish to bring to your attention that I did not say arteriole. So let's take a look at left anterior descending, which is the artery, and where exactly on the heart is it supplying? Take a look. Anteroseptal towards the apex. Okay, so I want you to go in that order of your precordial leads. Begin at V1, because that's your interventricular septum. Anterior 2/3 of your interventricular septum is your LAD. Used to be called, and still is, the Widowmaker, right? Massive MI. Woof. And you find an ST elevation, at least V1 through V4. V6, I'm going to leave that away. I'm going to leave that out. V5, that's more lateral. But at least no V1 through V4. Lateral walls. Well, with lateral walls, we have left anterior descending and left circumflex. Now, with that said, let's take a look at ST elevation here. And if you focus upon, please, V1, V2, V3, approximately in the middle of that page of EKG. And you'll notice that this would be an ST elevation. You see that crazy concave type of ST elevation. You can't miss it. Huge, massive, specifically in those precordial leads. Which coronary artery would this be? Left anterior descending. Is that clear? V1 through V4, you see something like this, and please know, I don't care which licensing exam that you're taking, all 12 leads will be given to you. And when they're given to you, it is imperative that you know how to interpret and do not panic. Once you panic, this whole thing looks like a blur. You focus here, V2, V3, V4. What are you looking at there? An ST elevation. And those ST elevations to you should indicate, oh, left anterior descending type of issues. Okay, now, what if it is the lateral wall? Then it's the left circumflex more so. And this would be your V5, V6. That is official. And we have lead 1 and AVL. Absolutely lateral. Left circumflex should be your focus here. Left anterior descending could be involved, but your focus, left circumflex. What about the inferior wall? This would be your right coronary artery. So therefore, your leads here would be 2 at approximately 60 degrees. And from physio and from your medical education, you know lead 2 is probably the most important lead in terms of proper depolarization of your heart from the base towards the apex. Is it not? Of course it is. So lead 2 becomes a very important lead to you in every possible respect. In addition to that, we have lead 3 and AVF, augmented foot. And that would be the inferior portion of the heart. If you find an ST elevation in those leads, then you're thinking about which coronary artery? RCA, right coronary artery. Now here, what we're looking at is exactly that. Take a look at lead 2. At the second to the bottom, you have lead 2, you have an ST elevation. And for the most part, you see something like that, and then you should be thinking, well, is my patient having an inferior type of MI? And if you take a look at the AVF, you'll notice that, take a look at AVF, you'll notice there as well, you call it a fireman's hat. If you actually take a look at that ST elevation and that QRS complex and collectively, and clinically speaking, or, just to perhaps for amusement's sake, is the fact that it looks like a hat that a fireman might wear. Huh? So, ST elevations 2-3 AVF. What coronary artery, please? Right coronary artery.